Good morning. My case is white mimic, presenting behalf of Medicine 5. Miss, Mrs. R, a 46-year-old housewife from Melapadi, she presented with abdominal pain and vomiting for 2 days. She had a history of low-grade fever for the past 2 weeks and loss of appetite for 2 weeks. History of presenting illness was an insidious onset, dull aching, pain in the right upper quadrant, and there was no radiation, no association with food. She had 2 episodes of non-bilious, non-blood-stained vomiting. She had a history of feeling feverish, no documented temperature, no diurnal variation of fever. There was poor oral intake, and the relatives had noticed a yellowish discoloration of the eyes with high-colored urine for the past 2 weeks. There was no cough, no breathlessness, no chest pain, no known comorbidities, and no habits of ethanol or tobacco consumption. On examination, her pulse rate was 110 per minute, cardiac BP of 140 over 70, and icterus was present. On system examination, on respiratory system, she had hemithorax expansion on right side of 0.5 centimeters and left side of 1.5 centimeter. Vocal fremitus was reduced and dullness on percussion on the right hemithorax with decreased breath sounds. The abdomen, CVS, and CNS examinations were within normal limits. So the clinical syndrome here was fever with right upper quadrant pain, vomiting with clinical findings suggestive of right-sided effusion with jaundice. The initial differentials we considered were enteric fever, a viral hepatitis, a disseminated tuberculosis, liver abscess, and a possible malignancy, liver malignancy with metastasizing to the lungs and pleura. So initial investigation, she was anemic. In the total counts of 12,000 with neutrophil predominant. She presented with a renal AKI. Serology for hepatitis A and E were negative. Blood culture showed no growth. LFT showed a direct hyperbilirubinemia with an AG reversal and transaminitis at presentation. So the X-ray, there was a right-sided peripheral homogeneous opacification extending from the apex to the costophrenic angle. When we went ahead and did an ultrasound, we realized there was an ill-defined heterogeneous hypoechoic lesion in the liver, possibly a liver neoplasm, and heterogeneous content in the right pleural cavity. But the pleural aspirate was dry. So we went ahead and did the CT thorax. There was extensive lobulated nodular pleural thickening with enhancements suggesting of calcifications. And the dense calcification in segment 2 of liver, also involvement of the L2, L3 disc spaces with a small psoas collection. So at this point, with the pleural calcification, our differential diagnosis were first could be exposure to asbestos causing pleural plaques. Secondary, relating to a malignant mesothelioma, a metastasis, a primary pleural lymphoma, an extraskeletal osteosarcoma, pleural effusion, empyema, and then finally a disseminated TB with the tuberculous pleuritis. So because the pleural tap was dry, we did an ultrasound guided pleural biopsy. It was ill-formed granulation inflammation was present. But the CT guided biopsy of the psoas showed necrotizing granulomatous inflammation. A culture grew MTB. So the final diagnosis was disseminated tuberculosis with pleural paravertebral involvement with psoas collection. So highlight here is that tuberculosis has a myriad of presentations, mostly pleural tuberculosis. When extrapulmonary, the most common is the pleural involvement, which presents like pleural effusion, secondarily leading to pleural calcification. But in our patients, a primary pleural calcification due to tuberculosis, which is an extremely rare manifestation of active tuberculosis. So on literature review, I could find 2 case reports. A similar report of a 21-year-old female. She also had fever, cough, and dull aching chest pain with pallor and decreased movements in the right side of the hemithorax. AFB was negative. Sputum culture showed no growth. Similarly, the pleura showed intense calcification. In her, the pleural fluid analysis, they had not sent an ADL level. Pleural fluid stain AFB was negative, bile aspirate was negative. She started on ATT for 6 months, and after which she improved. Similarly, another case report of a 67-year-old in the PET scan showed active pleural thickening, but an active pleural tuberculosis must be considered as a differential diagnosis when there is a pleural thickening. So TB pleurisy is a common inflammatory reaction caused by direct access of the mycobacterium. It's a dry and exudative phase. Initially, in the exudative phase, there is congestion and edema, which is a rather thick edema which enters and blocks the lymphatics, causing deposition of fibrin and fibrosis, eventually leading to calcification. But in rare presentation, and the direct involvement of pleura with MTB can also present as primary pleural calcification. ATT was initiated for the patient, and patient had improved clinically and symptoms had subsided.
Give him a hand. We have time for 2 questions for Gaurav. Anybody? Your initial list of differential, can you put it up? Was pleural effusion explained by enteric fever or viral hepatitis?
Yes.
Some of the thing is the initial differential should try to explain one disease with all the clinical findings. So that is one possible finding. Any other questions, comments for Gaurav? Right.
Duration of symptoms.
So she had 2 weeks. So she had 2 weeks history of low-grade fever and loss of appetite, with 2-day history of 3 episodes of vomiting with right upper quadrant pain.
Very unusual. You see so much of pleural effusion, but it never calcifies. And here, usually TB pleural effusion isolated organ involved. Here, liver is involved. Jaundice also an unusual symptomatology of TB. The patient is very atypical. And why TB should induce calcification in the pleura is also unclear. Something else is happening more than the TB, which is leading to multiple organ involvement with cancer. Do you have any thoughts about what that's happening?
So,
Sure, is there any exposure?
so there is no exposure. I could not find any literature review about why an active TB will cause a calcification. Yes.
Okay, thank you. Give one more hand. We have respiratory medicine.